I'm Dr. John Kruse, and today I'm going to be talking about stimulants, ADHD, and weight. The take-home message is that one of the best connections or best known connections between stimulants and weight is that stimulants suppress appetite and they stunt kids' growth. The message there is that they may be delaying growth more than cutting it off permanently. That effect is very small in most studies, actually maybe statistically significant, but small for height and usually not significant for weight. A much stronger connection is with ADHD and obesity, and there are three possible ways those could be connected. It could be that ADHD is contributing to obesity. All three of these seem to be present. That seems to be the biggest part of the connection. There are certain cases where obesity actually leads to ADHD. And then there could be a third factor, genetics, other environmental things that contribute to developing both ADHD and obesity. And there's some evidence that that's also pertinent. Not every study is completely consistent, but I'd say the overall consensus is that, yes, stimulants do suppress appetite. For most people, that's most acute in the first few weeks. And for many people, the vast majority, it is no longer in effect after 2 months. The other ways that stimulants could have effects on growth is interacting through dopamine interventions with growth hormone. When the studies are all crunched, the effect size is pretty small for height and non-significant in most studies for weight. It appears more that there is a delay in growth. So kids with ADHD, while they're on their medications, are lagging behind on the growth curve, but by young adulthood, 1 to 2 to 3 centimeters or smaller, shorter, that's about an inch. In some studies, no height difference is found, and again, the weight difference is found to be non-significant. Seems to be true in both genders, although males have been studied more as throughout most of the ADHD literature. One of the few things that there seems to be a benefit accruing from drug holidays. Specifically, it's holidays of taking the whole summer off, so multiple months out of the year, not on medication, weekend, or just briefer periods off stimulants do not seem to nullify this stronger association between obesity and ADHD. So this is an effect. Again, not every study is in perfect agreement, but the meta-analyses looked at more than 1 million people cumulatively find that both men and women, there's a strong association between ADHD and obesity. This effect is stronger in adults than it is in children, but the odds ratio is about 1.2 in kids. So that means for every kid in the general population, you'd expect to be obese. There's 1.2 times as many in the ADHD population, and obesity rates are varying country to country. For adults, the risk factor, the odds ratio is about 1.5. So almost 50% more adults are obese compared to what you would expect trending from the general population. I think that there's good elements of the body positive message, but the vast body of literature is pretty strongly indicative that obesity in and of itself, strongly a risk factor for cardiovascular disease, certainly for diabetes, and certainly for many forms of cancer. So there is huge health implications of why so many Americans and people globally are overweight and obese, and the association most rigorous between ADHD and being overweight has been most rigorously studied for obesity, but it does seem to extend to less significant or less severe extents of being overweight. Obesity, we know, is a significant risk factor for developing sleep apnea and maybe some other sleep disorders. Essentially, that the more excess tissue you have in your throat and neck and back to your mouth, the more likely that your airway is going to collapse when you are sleeping. Sleep apnea itself creates a number of ADHD-like symptoms, and there are numbers of studies, some case reports, some more extensive in both kids and adults, that if you reverse sleep apnea, you can reverse ADHD symptoms. So some might say this is only creating a fake ADHD, that technically, if another condition is causing it, then it isn't ADHD. On the other hand, we know that ADHD is a spectrum of severity. So there are certainly people who are subsyndromal and who develop through developing obesity, like sleep disorder, do develop full-blown ADHD. That doesn't seem to be the major connection between ADHD and obesity. Interestingly, at the very beginning of life, there are both connections between babies that are too small, babies that are too large, both developing ADHD at higher rates than the general population. The higher big baby risk is found in mothers with gestational diabetes. When they broke it down and studied it in more detail, it's particularly in mothers who are overweight before their pregnancy and who do gain excessive weight during pregnancy. On the other end of the spectrum, we've known for years that prematurity, but particularly small weight or gestational age, is a risk factor for developing ADHD, fetal alcohol syndrome, socioeconomic deprivation, others that contribute to rates of underweight babies. But comparing twins who shared the womb, the underweight twin has higher rates of developing ADHD. And when they looked at Wechsler intelligence rating scales, it seems to be the impact of low birth weight on what's called fluid reasoning. So your short-term memory or vocabulary and language skills don't seem to be meeting it. Your concrete knowledge and ability to manipulate facts. It's more what they call fluid reasoning that seems to mediate the effect of low birth weight on higher rates of ADHD. And there do seem to be a handful of genes that confer both a slightly increased risk of obesity and a slightly increased risk of ADHD. There are certainly suggestions that socioeconomic conditions, particularly poverty, particularly chaotic early environment, whether specific environmental toxins do or not. So one toxin that's been looked at for ADHD, phthalates, form of type of plastic, higher rates of maternal phthalate level is correlated with higher rates of ADHD. That condition, however, is associated with anything lower than normal weights, not with obesity. But they are still looking for other environmental factors which may lead to both. But most of the research so far, and it seems the biggest chunk of the interaction or the association between obesity and ADHD, is ADHD contributing to obesity. So there are a number of studies showing ADHD precedes obesity. Not all. There's some showing the reverse, some showing they may show up together, but several showing it precedes it. That again doesn't prove causality. So it could well be that a third factor is contributing to the development of both of these conditions at different periods of development. In general, not absolutely every study, but for kids or adults treated with ADHD, their rates of obesity seem to be similar to the background population rates, whereas again, untreated ADHD or treated with substances other than stimulants, kids and adults seem to have substantially higher rates of obesity. Both inattentive and impulsive factors make kids with ADHD eat less healthy, less nutritious diets. So the content of what they're eating, measurably in a few studies, more junk food. Reward sensitivity makes it more likely that, the highly processed, stuffed with fats and sugars and salt are going to have a bigger impact on kids or adults with ADHD. So there can be reward sensitivity factors. There can be more impulsivity in terms of making decisions. There can be inattentive factors that contribute to paying less attention to, again, the content of what we're eating. An area that I think has been neglected isn't focused just on the content of eating, although this interacts with it, is when people are eating. I mean, it's certainly been studied. Kids with ADHD miss breakfast more often than other kids. They are up later at night. I haven't seen actual studies looking at more eating at night, but there's a body of growing research, certainly in animals and other animals, but including in humans. The exact same number of calories consumed at nighttime are more likely or lead to greater weight gain than the exact same calories consumed during the day. So again, it may not just be the content of what they're eating, but when people with ADHD are eating it. We also know people with ADHD are in increased risk for eating disorders, including binge eating disorders. Interestingly, Vyvanse, which is a extremely popular ADHD medication, has also been approved for binge eating. So part of how stimulants may help avoid this weight gain isn't just, again, appetite suppressant effects, but they may well help regulate impulsive and inattentive behaviors that lead to aberrant eating. Even though on the surface you would think, hyperactivity, that should lead to lower weight. And there is some evidence that even minor fidgeting is, over the course of the day, a considerable use or expenditure of calories. So a fidgeter compared to a non-fidgeter would be likely to gain less weight or lose weight relative to the other. Again, with ADHD, what we've seen when we've broken things down is kids with ADHD, much less studied in adults, but are less active. They're more sedentary. They're spending more hours in front of television, more hours in front of social media and video games, less hours in exercise. Most people with ADHD find it, if they enjoy exercise, the commonest pattern is they get interested in one activity and race through it or burn it up in a few weeks or months and then fall off track in weeks or months or years before they get back to anything. Basic symptoms of ADHD is difficulty in expending energy on something that takes sustained effort or mental effort or physical effort. What can we do about this? One is, again, this is a strong case for medications can be helpful. And what I say is you should schedule the big four, the essential four, before you're scheduling any work, before you're scheduling any school time or effort. So the big four are: when are you sleeping? When are you eating? When are you exercise or moving your body? And how much me, which is me for meditation or relaxation or enjoyable time. Those you should put in your schedule first. Those are all essential for life. Once you have them in place, then you can figure out when you can tackle work and other things. If you don't have those in place, you're not going to be sustainable in any work or school effort. One of my diagnostic tests for ADHD over the years has been if someone says, oh, it was 4:00 and I realized everyone else at work was, I'd gone home and I realized I hadn't eaten for the day. There are certainly people who consciously do not, eat in the morning or skip a meal, but for inadvertent skipping a meal, that is a pretty good diagnostic indicator of someone with ADHD, particularly if it's happening habitually. So planning meals, when you're going to eat them, and again, regarding circadian factors, when you eat your meals probably has some significant impact on how much weight you are gaining from it. And these are, borrowed from general weight control tips, but particularly important for ADHD. Don't leave tasty treats in view. Put them away in cupboards. It's on the countertop. It's on the kitchen table. If it's visible in the breakfast nook, if you see it, you're much more likely to eat it. It's not object permanence, but it's that out of sight, out of mind. If you're not seeing it, you're going to be less likely to be triggered. And again, for addictive behaviors, visual cues are potent triggers. And then sort of following up on the scheduling planning, one thing that's difficult for people with ADHD is planning. So if you develop shopping lists, get into the practice of developing shopping lists, not buying impulsively food that's on the list. If it's not in the house, it's not available, then it's going to be a lot harder to binge on it or overeat on it. With increased working from home that we've seen since the pandemic, that's been very disruptive to many of the people I work with ADHD in terms of their meals, particularly in the Bay Area and tech firms. Many of them counted on a healthy, nutritious options for lunch, certainly, and many for lunch and dinner. This isn't within the budget for everyone, but I've had patients who subscribe to meal providing services now that they're working from home all the time, but that just cut out the worry, the time commitment, the planning that they needed, and ensure that they had a steady supply of healthy meals available when they needed or wanted them. So that's about all I'm going to say. I think I haven't left anything salient out. I do see at least one question. How do psychiatrists distinguish between depression due to MDD and depression due to burnout? I mean, one is there's a range of opinions on this, so I don't And some of this is how are we defining things rather than are these different things? So certainly the stress of feeling that you're working too hard, too long, and are underappreciated. I mean, we know that there are biological factors that contribute to depression. We know that there are social and psychological factors, and burnout can certainly be a primary one. Some people would say if the distress, dissatisfaction is mostly focused on the work environment, and when you're out the work environment, if you're enjoying your hobbies on weekends, if you're participating in other activities, you're socializing with your spouse, you have one, your partners, your kids, if you are taking care of your health and diet, as we talked about here, if your sleep is good, then that may be more likely to be a problem with burnout than just with depression per se. I mean, they're clearly overlapping concepts, and clearly burnout can contribute to depression. And again, certainly what some people are calling depression would be full-blown MDD, major depressive disorder. Can you speak about new forms of methylphenidate like dexmethylphenidate and their efficacy compared to the original dextroamphetamine compared to levoamphetamine? Dextroamphetamine is substantially more potent. There's differences in the relative effect on norepinephrine and dopamine, and some of that's there with methylphenidate as well. Clinically, what I see far and away the biggest impact is the time release or the duration of effect in terms of slow release mechanisms versus immediate release mechanisms, and variation in how long slow release mechanisms are starting and whether they're starting fast or have some immediate release to kickstart it. I know that there are people arguing that there's differences between dopaminergic and noradrenergic symptomatology in ADHD. I know there's people who are arguing that there are frontal attentional systems and posterior attentional systems. I just have not seen in individual patients much clinical people saying, oh, Hansia or Ezekiel or this product works so much better for me, and it's because of this difference in the relative ratio. Again, most of these products are just tweaking the ratios subtly. They're not dramatic. I'm not saying that they may not have some differential benefit, but I see them almost entirely as marketing tools. They switch the ratio a little bit and they get a patent, and then they can market it and produce studies. And again, I think far and away bigger factor seems to be timing. So something like Jornay, which is a novel timing mechanism, has a potent difference in how it works and how well it works with someone's life. So I'm not saying that there aren't individuals who may notice and experience substantial differences. Lots of patients I work with are highly educated and highly motivated and searching. I've seen effects, I think, are placebo effects, where the first few days of trying the new agent, wow, this has worked better than anything. And then a month later, feeling about the same as I did on Concerta or something else. I don't actually consider Ritalin really a stimulant. On so many measures, it is closer to the non-stimulants in terms of performance and in terms of bad side effects. So it is more like Strattera, more like duloxetine, Cymbalta, more like Wellbutrin, more like modafinil in some ways than any of them are like amphetamine products. Stay healthy, stay happy, have a good week.